I'm Dr. Marcia Sonity,
And I'm Dr. Caleb Moore,
and this is
the Free Smiles Podcast.
Well, today I have a few topics that I would love for us to cover.
Yeah.
We are talking about cracked teeth
Mm-hmm.
and the prevalence, diagnosis, and really just the prognosis of them. What we can do as providers to educate our patients and other providers on how to see cracked teeth and really understand, risk assessment where that tooth is heading. Some of the things that, I've done some research on this, and I think that overall cracked teeth are really misunderstood. Would you agree with that?
I think misunderstood's a good term. I also think they almost can carry a either over-exaggerating response or an under-exaggerating response. So it can be like, oh, you have a little crack, or it's oh, your tooth is fractured, and so I think there's two different ways of looking at it, and I feel like how we present or educate patients on it is where we get the outcome that is more predictable for that patient.
I agree. I think that it's misunderstood in the sense of every crack is considered hopeless, or if patients think I have a cracked tooth, that there's nothing that we can do, right? And that I don't think that's the reality for 80% of these cases. But I think that what we'll do today is just shed some light on what we're looking for, and really the biggest thing for me is early detection.
Yeah, I think a huge part of the early detection is really using, we have so much technology now, even something as simple as intraoral cameras. Obviously there's 20 different kinds of intraoral cameras you can buy, but I think even the most simple, basic intraoral camera is going to be very useful and helpful to patients. I think if your office doesn't have an intraoral camera at this point, you're years behind the times. You know what I mean? That's something that even if you're not fully digital with your charts at this point, even if you have a simple, a laptop in your hygiene room or something that's connected to some kind of digital system like that. And I think that's just the patient education, the understanding of that part of it is huge. And that goes along with, there's other, outside digital cameras, there's transillumination devices, there's caries detection devices, there's intraoral digital scanning.
Yep.
There's a plethora of options for not only patient education, but helping us see things. So I think that's huge.
I love that you said that, because one of the things that I tell patients every day is I love to analyze data. I'm a nerd. I will read, research articles. What I'm going to do today is collect data, right? And then we can analyze it and come up with a plan together. So, like you said, we have all of these tools at our fingertips, intraoral cameras, or at least we should, transillumination, even an iTero scan of the tooth that you can blow up and show them, this is where their crack is.
And they can go home with those photos.
Exactly. And those are all great places to start, because then we have that to back us up in what we're saying. And I think, though, a good place to start with this is, what type of questions are you asking? So if you come in for an exam and your hygienist is taking a great intraoral photo, and we notice a crack on a tooth, what are some of the things that you're asking your patient?
So if we're noticing, we take a lot of photos. Now we're doing scanning on a annual or semi-annual basis, so we're getting more comparisons. But to me, it really depends on what's happening with that. Does that patient is this the first crack in they have pretty much, a virgin dentition? Have they never had anything really occur in their mouth, and now we're seeing these things? I'm typically asking patients if they're having any muscle tension, soreness, kind of getting to the roots of, are we having some kind of clenching and grinding? I'm getting into some sleep questions with that and some TMD stuff, just to kind of find if there's a root cause for some kind of change.
Absolutely.
If it's someone who's had a lot of restorations and they've had a lot of crown work, I'm also going to be analyzing, where was this, what's happening with this tooth? Does it have an old amalgam filling in it? Is that just a tooth that's kind of been on the radar of a previous provider, and now we're seeing really changes in dynamics in that? And just with updated technology, I am asking a patient, hey, we're seeing this today, it's looking this way. I know maybe 6 months ago or a year ago, this is what the perspective was, but say this is what I'm seeing. would you like to be more proactive about this situation, or do we want to be reactive when and if, I mean, mostly when this propagates and becomes more of an emergency problem? Do we want to deal with a call on a Saturday night, or do you want to deal with, hey, let's treat this problem today or within the next couple of weeks, so that we avoid kind of that catastrophic event, is what I kind of describe it as.
It's easy for us to sit here and be like, let's get to the why, but a lot of providers aren't doing that, and I think that you should be proud of yourself, number one, because I think one thing that we just do innately is get to the bottom. Like you said, we've talked about since we started this podcast, there's a genuine curiosity of why things are happening, and patients really appreciate that, because if we are fixing something to a broken system, it's just going to break again, right? And I think that's invaluable, what you're doing. Another thing too, some of the other questions that I think are really important is like, are you having pain? Are you symptomatic? Is there pain when you're chewing down or when you let go, right? Or when you open your mouth? Is there a relief? What are you feeling? And it all comes back to the word that you said, propagating or propagation. That's going to tell us how deep that crack is and what level it's at, so what do we do? What do we do then, right?
Right. So I think, yes, proper testing. So whenever we're seeing a crack in a tooth, so say if someone's coming in for like a periodic or, their 6-month cleaning and then checkup and things like that, it's a little bit more, we're kind of looking at everything.
Mm-hmm.
And then if someone's coming in for a limited exam and they're telling me, hey, I'm noticing some symptoms, it's a little bit of a different conversation. Because when someone's already symptomatic, I know that crack is propagating to the point where it's so deep into that tooth where now your nerve is now feeling that.
Yep.
So what we call a surface level or an initial kind of crack or fracture is something that's not symptomatic. You're not going to feel that until it's getting so close to the nerve where it's big enough that it's actually starting to kind of wedge the tooth open.
Yep.
So when you bite down and release, that is when that tooth is actually separating or splitting. So when that's happening and we're having symptoms, then those are the situations that, yes, it's likely that we can still treat that. It's going to be a crown or some kind of onlay, something that's going to be a full coverage of the cusps involved into that crack or fracture. And then when we're preparing that tooth, we're taking more intraoral photos. I'm kind of diving deeper when I'm, taking layers off just to see how far is this fracture going and is it going beyond my prep. So then I'm like, hey, we got to this point, we're not going to prepare this tooth more, but we're going to be preparing you for the crown and shaping it. And then we really just need to kind of monitor and watch this, especially if it's coming in symptomatic. That tooth can, hopefully ease up with that symptom over that course of being in a temporary. But if it's not, then we're already talking about doing either a root canal or if we're, not wanting to save the tooth, or the patient's like, hey, we have these other factors that maybe don't give it a good prognosis. And we're talking about extraction and then potentially root canal or, potentially implant or bridge, if anything, or a removable device if that's, the case.
Exactly. And one thing that I want patients to know always is like, this could be a slippery slope, right? If we don't have early detection and we don't treat this, earlier, that ultimately it's your decision, but this could lead to this, right? And if we're saying no now, then you could be down the road of extraction. So I think that's a really good point. One other thing that you said was, testing. We're going to complete the testing today. What are you looking for with transillumination? Explain that a little bit to me. What does that process look like for you, for doctors who may not be utilizing it?
Yeah, I think there's a couple different, what I would call light illuminating devices. One really simple way, so if you don't have, there's actually a transilluminator, so especially for posterior teeth. So for anterior teeth, you can transilluminate with a mirror and just kind of reflect the ambient light behind the tooth and then see caries detection or initial fractures and things like that. When it's a posterior tooth, you're kind of in a cave. So we're either going to use a transilluminating device, which is a little light that you shine on different parts of the tooth. You see if that light passes through. You can easily use a curing light can be used as a really, every dental office should have a curing light. So you can use that as kind of like a makeshift transilluminator because it can shine light into a side of the tooth. If it has an amalgam filling, if it has a fracture, you'll see different kind of light reflection into that. But if the light's reflecting all the way through the tooth and you don't get a stop or a break in that, that's going to tell me that the fracture isn't a complete fracture. It's not cutting off that cusp or that part of the tooth. We also have it's called a carry view. So what it's doing is actually putting near infrared light on both sides of the tooth. So it hugs the tooth, and that's more for, it's good for caries section, but also just like illuminates the whole fracture from like the base up and lets me see kind of little hairline fractures as well. Because sometimes the ones that we see are like those big ones that are already, they've been there for a while, there's some staining going on, they're kind of highlighted. You can see with the neural camera. What the carry view does actually illuminates the whole tooth and gives me even those nuanced cracks that we'll probably miss with the naked eye, or, you know, you had to have the tooth super dry to see them. So those are the, I guess, couple tools that I use. I use the carry view a lot, really with most things I'm detecting. Yeah.
And when you're going through, you know, these tests with the teeth, is it the same way every time? Like
I try to have a process.
Yes, I think it's really important that as providers we run through the same thing every time. So, you know, we're human; things can get missed, and what I find is a lot of providers just send to the endodontist. They're just like, okay, I'm going to send you.
Oh, that's
But
interesting.
I think that.
I don't think I would ever do that.
Well, I know,
And
right?
now I'm thinking about that. I was like, wow, I don't think I would ever have someone come in, tell me a couple things, and then be like, here's a referral.
Let's just send you.
Yeah.
No, I think that.
Unless I have a history and I know that's where it's like the tooth's going or something like that.
I think that it's case by case,
Yeah.
and I'm not to say that there's not a place for that. There are times where we do need to just send the patient directly to endo, but I think with cracks it can get. I have a specific case in mind where I had a patient who I went through percussion testing, so I went through that, endo ice testing, tooth sleuth, and the results were really inconclusive. And I'm like, you know, this tooth is testing fairly normal. You know, she's not symptomatic, but I can tell from the X-ray that we have a little bit of condensing osteitis going on. There's something happening with this tooth.
Something
and
reacting.
Exactly.
Yeah.
So there's some reaction going on. I don't feel comfortable just leaving it as is. You know, leaving it as is and not doing anything about it.
Yeah.
So I sent her to an endodontist. And kind of like you were saying earlier, when we talk about how do we move forward when we notice a crack, what are the things that we're thinking about? What are the options? How do we explain that to patients? This was a perfect example of that. I sent her to the endodontist and he said, I'm going to send you back for a crown. And what I had explained to the patient was, you may not even need to see the endodontist. However, if it were me and I was in the chair, I would want peace of mind, knowing that things are questionable on the X-ray and that we're noticing early signs of this. They may say that you don't need the root canal yet. However, there's definitely a fracture happening, and whether the extent of that is to the nerve or not, we really can't determine that until, I mean, we have tests, but we can't determine that unless we go to prep, right?
Exactly.
Once we start prepping, then we can tell how far that's propagated.
Yeah, you can look at a lot of things, and also I feel like it's kind of understated just like what it is to like temporize a tooth properly, and then kind of have a certain kind of occlusion that's on that tooth during that time that's allowing it to kind of relax and not be, you know, too high in the bite, but not be completely out of occlusion, not be in certain movements of that person's chewing patterns where you're allowing it to have relief, but also not, you know, taking it fully out of occlusion, unless it's like a certain situation where we might want to do that. But I think just the little nuances of not taking every single, I mean, we need to have steps and like things that we follow, like what you're saying. Like when someone comes in, the exam that I'm doing, even if it's the localized tooth that I'm looking at, I'm still doing like a TMJ assessment and kind of looking at their, like, how does their jaw, you know, open and close? How does it deviate either way? Are we getting more muscle tension on one side or the other? Those things are telling me like bite relationship, you know, chronic things over time. And then when I'm, you know, kind of pinpointing onto a tooth, and then hopefully it's a simple situation like, oh, we got this tooth, that's the situation, or we have this infection going on. But then I'm, you know, palpating the alveolar ridge on both sides. I'm doing my percussion testing, endo-ice testing. I'm checking the periodontal status of that tooth as well, and the surrounding teeth, because you can have a perio-endo situation happening. And I feel like that's one thing that's missed the most. Is because in dental school, I feel like most dental students want nothing to do with perio. I feel like we are very comfortable with the perio probe because of our hygiene history. And to me, if I'm trying to kind of find the root cause of things, there's very much and you can also rule out a vertical root fracture with your perio probe. So those are the things as far as like why do we do these tests? It's giving me all this information.
Yeah, and the more information we have, the better, and the more supported we are in having the communication and the conversation with the patient about what's going on. I actually wanted to segue into vertical root fractures, which is
Well, you're welcome.
amazing. Because when we talk about the propagation, and I actually want to take it back to the crown for a second before we go into the vertical root fracture. When we talk to patients and we're explaining, this crack has started, and now, let's go back to my case where the patient came back from the endodontist and they had supported me in the sense of, you do need this crown, which was amazing to have that support from another clinician and having the patient hear that and feel comforted in the sense of, now I have two providers telling me the same thing. It's amazing. And he's actually on the board of endodontics, which is just amazing as well. But anyway, so patient comes back and we do the crown. Why are we doing the crown? When you're explaining to patients, we need to crown this tooth, what's the reasoning behind that?
Yeah, so especially if it's a symptomatic crack or fracture, the kind of reason for having a full coverage restoration that isn't what we call a direct restoration is going to be like a composite, something like a filling. It's, it would be a filling. So what a filling is doing is we're, removing a certain diseased part of a tooth, and then we're bonding to the inside part of the tooth. So we're essentially excavating the inside and then putting something in the middle of a tooth.
Yeah.
When we are looking at a crack's already splitting a tooth kind of either sideways or lengthways.
Mm-hmm.
So what a crown is going to do is actually take the whole splitting part of the coronal part of the tooth, and it's going to encapsulate it into either a porcelain or whatever your choice of, gold or whatever you want to use for your crown. It's going to encapsulate that and actually act more like a protective, almost like a vice grip. Like it's going to squeeze that tooth and allow that crack to actually not propagate. So when you go to chew down, you don't get that flexure. So you likely and hopefully won't get continuation of that crack propagating. If it's surface level enough where we can just do a crown, then we can prevent a root canal, prevent that crack from propagating. So it's almost like, if you're trying to fix I'm trying to think of an example.
Like a windshield.
Yes.
Yeah.
Yes.
Yes, like a windshield on a car.
Yep.
So that came to mind. I don't know. I tell patients, I'm like, think about, if you have a crack on your windshield and we don't stop that crack before winter comes, what's going to happen? The windshield is not going to be savable.
Yeah, but
right?
Think about your windshield being something that you literally chomp on every single day.
Exactly, right?
The amount of, I think people underestimate, the pounds of pressure that your teeth take every day, especially when we're talking about more posterior teeth moving forward. And it's just so interesting to me. Each tooth has its own, little story in my mind when I'm looking at people's mouths. I'm saying, okay, this is your second molar. It's taking a huge amount of force. If I'm seeing a crack there, that's more likely going to be a propagating crack that's going to happen a lot faster versus, maybe a mandibular second premolar, which is really not the highest end of occlusion for most people. Some people do. And then I think about a premolar to me is the most likely tooth that's going to have a catastrophic fracture without having any warning. And I see this all the time.
Oh yeah.
It's that person that comes in for their recare and they're like, yeah, I got a little bit of tenderness up here. You take a look and that tooth is literally split in half, through the root.
The lingual cusp is just wiggling.
It's just wiggling. Yeah, exactly. Because it's just the physics of where that tooth sits in the mouth. It's the physics of how that root structure is with its big crown. And I just had this conversation with a patient maybe yesterday or the day before, and she had, filling in the middle of the tooth, 2 cracks going down either side of her premolar. And I said, listen, we could be proactive or reactive here. It is your choice. Everything is your choice. It's your body. But I'm going to see her in 6 months if she doesn't choose to do it. And then we're going to be talking about maybe, something else happening at that point.
Okay, so let's say she's like, I don't want to be proactive. Thank you for all of the information. I understand, but I am just going to see how it does, right? Mm-hmm. She comes back in 6 months and she has a vertical root fracture. I want you to touch base for younger docs who may be listening. How are you finding that vertical root fracture?
Okay, so...
If it isn't obvious.
Yeah, usually it's going to be real close. So symptoms are one thing, but also I feel like the perioprobe is like your best friend in that
Yeah.
situation because a tooth, if you're not very careful with like exploring and looking around teeth when you're doing your exams, sometimes we kind of brush over little things. But that's why I think documentation is super important. Like this tooth is treatment planned at this point in this person's chart. I'm notating where these fractures are. I'm notating that conversation that we had. Because if she comes back in 6 months, I'll be like, wait, was this here in 6 months? And I have a photo of the tooth and I have a photo from before, or whatever that may be. But the perioprobe is going to tell me where the location of that fracture propagated. I mean, I know it's going to be mesial or distal in this situation, just from experience. But just dropping the probe down, or even having your hygienist, if they're doing their pocketing, just be very diligent when it comes to that, like really walking the probe step by step, not like one probe per side of the mouth, like side of the tooth. And that's a huge part of it. Obviously, like tooth sleuth, bite tests and things like that. But I feel like the perioprobe is going to be my number one best friend, even before an X-ray.
I think that there's so much power in that little ruler, right? Like so much power in that. I had a patient come in and she needed an extraction. But for the day, the hygienist was just spot probing. She came in spot probing and was like, yeah, everything looks good. Bite wing didn't show. It was a perfect storm. It was a perfect storm of missed opportunity. When that doctor came in and found the tooth that needed to be extracted, there's so much power in saying, hey, I took my probe around this tooth today. I am seeing an area that's really concerning me. And if you're not walking it all the way across the tooth around the whole side, you're not going to find that. And you're not going to be able to have that conversation.
Yeah, it's a lot of due diligence when it comes to that. And that's, I don't know, I feel like that's just part of those 5 steps that I do at every limited exam. Even if I mentally know what's happening, I'm still going to do those things because I still need to mentally, it's almost like I won't sleep at night unless I do these tests. Yeah. Because then I'll be like, okay, even though I know what's happening and I diagnose the same way anyways, it's almost like you just need to go, it's almost like an OCD thing. I don't know. Not that I'm an OCD person, but I feel like, okay, let's not get into that. I feel like just going through those steps, it's almost like you're just, I don't know, it's part of just the ease of completing something properly.
Yes.
If that makes sense.
No, it does make sense. Yeah. And I think that, and we've talked about this before, but when you're following a system, whether that's just how your morning routine, how you take care of yourself, there is less stress involved in your life. I don't have to stress and worry that I'm going to miss something if I know that I already have a system that I'm following every time. Okay, this is what I'm doing first, second, third, and it's all covered, right? Mm-hmm. And I think that's really important. So, following all of the testing that we talked about today, parabellum charting, right? Percussion testing, tooth sleuth, transillumination, endo-ice testing, gathering all of that evidence. Another thing that I'm finding is there's so much power in telling a patient, I need a few minutes, or even if you just take a PA or a CBCT, I need a few minutes to see how this testing, this data that we collected today, matches up with what your imaging is showing, so that we can come up with an accurate plan.
Yeah.
I think
especially if I'm taking a CBCT. That's sometimes when things are obvious, it's like, okay, we just go through it. But sometimes, and I'm lucky to work with a really good surgeon and 2 other really good doctors because, there can be a patient, it's not very often, but sometimes you have a patient that comes in, they're having these couple things happening, and they're not really checking all the boxes of where you would put a diagnosis or kind of like a differential. And then you take a CBCT, or you're trying to figure something out, and then those are those patients that I'm like, hey, I'm probably going to give you a call tomorrow just to, once I get a second to because especially with a 3D image, you really want to sit there and I'm doing it in my mind,
section
going through
by
all
section.
the sections, and you're moving the little cursor to is there something different? Yeah. Especially with resorption teeth and things like that. I think I'm better at spotting it. Way better than I used to be, but it's one of those things that if you're not just taking a couple seconds, even on someone's bite wings, the check x-rays that we take every 6 months to a year depending on the person, and I've spotted more resorption just from taking a second to be just do and then same thing when I'm looking at a pano x-ray, I'm following the same kind of lines, so I know I'm looking at all the things on there, and it makes my life feel more fulfilling. That I'm actually
my
just
gosh.
like,
Yeah.
Not just going through the motions, I guess.
No, not going through the motions, actually following a system that is going to help the patient long term. But yeah, I think this has been very enlightening on cracked teeth.
Yeah.
It's really important to know that early intervention is key and to just discuss risk assessment with patients and let them make the choices. And then, follow your systems. And if you guys have any questions, let us know.
We're here.
Okay, we'll
See you
see
next
you next week.
Thank you so much for listening. If you enjoyed this episode, please share it with a friend. Don't forget to leave us a comment, rate us, and subscribe so you never miss an episode. We appreciate your support and look forward to bringing you more great content.